Beatrice Rivalta. I'm a pediatrician and I'm in the last year of my PhD in clinical immunology in University of Rome Tor Vergata and Bambino Gesù Children's Hospital. It's my pleasure to introduce Lorenzo Lodi. He is a pediatrician working in immunology at Meyer Children's Hospital in Florence. In recent years, he trained in Florence, but also in Boston Children's Hospital and in Paris at the Imaging Institute and Necker Hospital with Yanchuk Crow and Marie-Louise Tremeau. More recently, he has been collaborating with different European centers on type-I-interferonopathies, but also with Stefan Hell and his group in Freiburg on STAT3. Today, we will discuss an interesting clinical case of inborn error of immunity with an optical presentation. This case underlines the importance of functional tests and in-depth characterization of our patients, but also the importance of collaboration between biologists and clinicians from different European centers. So I give the floor to Lorenzo.
Thank you. I'll try to share my screen first of all.
Good.
Can you see it?
Yes.
You see the presentation?
Yeah, go ahead.
Okay, thank you everybody for being here, and thank you to Dr. Beatrice Rivalta for such a nice introduction. Special thanks to our junior party chair, Antonio Marzollo, who invited me and gave me the opportunity to share this case and our group's research on it. And more in general, thanks to ESID that gives a lot of space to junior members to learn and interconnect. So it's obvious that I'm going to talk about STAT3 germline disease. I did it on purpose. I put the name of the gene directly in the title because as immunologists, we are a little bit obsessed with the identification of the gene of the monogenic disease, and this is correct, whether possible. But in this case, I didn't want you to focus on that because I think it has a lot of message to give beyond the diagnostic pathway that led to the identification of the mutation on STAT3. So everyone that is familiar with STAT3 germline disease knows that up to now it is divided in a sort of very dualistic way in two diseases because some mutations are responsible of dominant negative effects and finally in a sort of loss of function of the gene product, and this is responsible of the autosomal dominant hyper IgE syndrome that everybody knows is characterized by a specific infectious profile that regards especially the lung and the skin with staphylococcal infection and also mucocutaneous candidiasis and skeletal abnormalities. On the other side, there are other mutations that confers a gain of function effect to the gene product, and these are responsible of a newer entity identified in 2014, that is STAT3 gain of function, that for the moment it has been considered as a sort of counterpart of the autosomal dominant hyper IgE, where the autosomal dominant hyper IgE is sort of loss of function, infection, and on the other side there is a STAT3 gain of function disease that is more lymphoproliferation and autoimmunity. So with this in mind, I will start with the case. The case is the case of a girl that first went to rheumatology consultation with a complaint of persistent xerophthalmia, recurrent episode of skin hyperemia of the face and the chest, and recurrent vaginal dryness and hyperemia. The colleagues in rheumatology performed lab tests and found mild eosinophilia with augmented erythrocyte sedimentation rate, hyper IgG, ANA positivity, and anti-Rho SSA positivity. Also, they performed a salivary gland biopsy. They found a focal lymphocytic steatohydritis grade 3, and the Schirmer test was positive. So they could perform a diagnosis of primary pediatric Sjogren's syndrome because the EULAR 2016 criteria were fulfilled, and the patient was put on hydroxychloroquine during a month. Unfortunately, The patient developed an erythematous itchy skin rash at the limbs with pustular evolution during this period, and they had a resolution when hydroxychloroquine was discontinued and a reoccurrence after reintroduction. So the patient was sent to allergology consultation, and they demonstrated that the patient was having a similar reaction when doing patch test with hydroxychloroquine, and for the first time it was documented an hyper IgE. So the patient came out from the allergology consultation with a diagnosis of acute generalized exanthematous pustulosis dependent on hydroxychloroquine, and the recurrent episode of skin hyperemia were classified as chronic urticaria. The patient was, the hydroxychloroquine was discontinued. She was started on methotrexate for the treatment of primary pediatric Sjögren's syndrome, and the chronic urticaria was managed with the use of cetirizine daily. During the follow-up, the patient also developed an alopecia during methotrexate, so methotrexate was discontinued and the patient was started on mycophenolate mofetil. And also she started developing some episodes of infection, like dental abscesses, and the episode of genital hyperemia were tested, and they tested positive for Candida albicans, so where they were considered sort of mucocutaneous candidiasis. Anyway, a recurrent episode of genital candidiasis in a patient that wasn't having sexual intercourse at the moment. Because of this episode of infection, immunology consultation was asked for the first time, and here there is the first message, that educational message that I want to give you. This first message is that in general, all immunologists knows that we have sort of made a step from primary immunodeficiencies to inborn errors of immunity. This is maybe not clear for other specialists that still have this paradigm of immunology to call the immunologist when there is a recurrent infection profile. We know that inborn errors of immunity can also have plus manifestation. This manifestation of plus may be autoimmunity, like everybody knows, but also autoinflammation, also lymphoproliferation, also hemophagocytic lymphohistiocytosis. So this first message that maybe is obvious for immunologists is to try and spread the fact that has a relatively recent paper has shown more than 1/4 of patients with inborn errors of immunity do not present the first time with an infectious profile, but with other plus, let's call the infection minus manifestation, because there is a loss of the defenses, and on the other side we have plus manifestation, like the one that I've said before. So the immunologist sort of reviewed the past medical history of the patient, and it came up that the patient actually had a significant infectious profile, because she has already had 4 episodes of pneumonia at preschool age. She was suffering of recurrent infection of the upper airways and recurrent otitis media, and the dental abscesses were due to 3 retained primary teeth that needed extraction. We already know that the episode of genital hyperemia were documented as recurrent candidiasis, and she also had 1 episode of oral candidiasis. So for those who work with inborn errors of immunity, this clinical picture seems quite obvious. This is the NIH score. Everybody knows the potential limitation of this score, but still it's very used in clinics, and the patient had a very high score, so we decided to send the patient to genetics, and we performed a next generation sequencing panel for inborn errors of immunity, obviously including STAT3, that is the most obvious candidate in this case. we have a clinic that is compatible with autosomal dominant hyper-IgE, and a de novo mutation, this PR335W on STAT3 was found, and it was already reported in literature in a paper. 2 related patients were reported in 2008 with the exact same mutation and a clinical phenotype of autosomal dominant hyper-IgE. Here you can see them. So, end of the story. We have a patient that has some clinical features that reminds us of autosomal dominant hyper-IgE. We perform the genetics, we find a mutation on STAT3 that is already being described, and that's all. Unfortunately, or fortunately not, because we start asking questions, because there were some elements that were not fitting. For example, the patient had a normal number of T-helper-17, a normal representation, and it was in this moment that we start talking with some friends in Freiburg, because some elements were completely fitting. It is true that the patient had all these clinical features that reminded us of autosomal dominant hyper-IgE, but the clinical picture was dominated by an autoimmune manifestation that was the Sjogren's syndrome. And we all know that Sjogren's syndrome, the Sjogren's syndrome itself had been associated only once with the gain of function phenotype, but more in general, autoimmunity and organ autoimmunity is much more frequent in the gain of function phenotype instead that's in autosomal dominant hyper-IgE. Plus, the patient had a normal representation of Th17. Here you can see the level and the percentage representation of Th17 in different domains, in different mutation affecting different domains of STAT3, and here you have the controls, and you can see that there is a lot of difference among them. We performed a first staining of Th17 using superficial markers, and then we asked Freiburg to perform a test using interleukin-17 staining, and also they compared the value with other STAT3 gain of function patients and other ES patients, and absolutely the value was not compatible with hyper-IgE. So we start questioning whether the patient really had hyper-IgE, an autosomal dominant hyper-IgE syndrome. And we came back to clinic, and what we realized is that it has recently been shown by a big cohort paper that sort of described the clinical story of STAT3 gain of function, that many features of this disease are actually shared. But our patient actually had, in bold you can see the most prominent feature of the 2 disease, and the patient had both of them, both in terms of clinics and both in terms of immunophenotype. Also, this recent paper actually has shown that many STAT3 gain of function patients also have facial features that couldn't be described at the moment because we still didn't have that paper. So we were also lucky because while we were discussing with our colleagues in Freiburg, we also found this very big paper from the Casanova group in Rockefeller, written by Asano, where he aimed to understand the mechanisms let's say, he wanted to see whether all the mutations that were responsible of autosomal dominant hyper-IgE were acting as dominant negative mutation. And what he has done is to take all the known mutation and perform functional assays. And as you can see, the white lines are the functioning of wild type. Instead, everything that is blue are hypomorphic mutation. And you can see that the totality or the overall totality of mutation that were known to be responsible of autosomal dominant hyper-IgE were actually hypomorphic mutation. They are all blue, except for 2 of them, and one of these is R335W exactly. And in particular, it does not only have a normal profile, it has an hypermorphic phenotype. it seems that the activity of this mutated STAT3 is much more than that of the wild type, so completely different. The authors in that case, obviously, they had another goal in their paper, but they just said that maybe other causes of hyper IgE should have to be sought. Other genetic causes of phenocopies of hyper IgE should be sought in those patients. We were thinking that a de novo mutation and a sort of congruent phenotype was enough to describe that gene, also because no other mutation were identified in the panel, including a lot of other inborn errors of immunity. And so we decided to go deeper on that gene. And this first functional testing that was performed in another lab showed actually a gain of function effect. We decided to perform a similar test in a STAT3 null colon carcinoma A4 cell line, one transfecting only the mutant allele and the other one transfecting the mutant allele plus a wild type allele. And what we can see is that in the sort of heterozygous model, our mutation has a phenotype, as an activity that is very similar to wild type, but this is also true for another known gain of function mutation that instead in a mutants only model has an hypermorphic effect, and also our mutation in a mutants only model has an hypermorphic effect. So actually we have two different methodologies, two different cellular models that are saying that our patient actually has a mutation that is actually a gain of function. We also performed a phosphorylation kinetics, and as you can see, during time, our STAT3 takes longer to dephosphorylate. And this is another sign of gain of function effect. Also, we decide to go and see what happens to the target genes induced by STAT3. One of them is a negative regulator of STAT3 that is induced by STAT3, and this is SOX3. And what happened was something that was quite unexpected, because all the data that we were collecting were pushing us towards the gain of function. But in this case, we see that especially after stimulation, you can see it here, SOX3 is there is a lower expression of SOX3 in our patients. So actually we were facing a patient that has clinical features of autosomal dominant hyper IgE, but with a significant autoimmunity. It also has a peripheral immunophenotype that is not fitting with what has been normally described for autosomal dominant hyper IgE. And we have also functional testing that is congruent with this hybrid and confusing phenotype. So to get to the conclusion, the first thing is that the clinical presentation of autosomal dominant hyper IgE and STAT3 gain of function disease may overlap. We have seen that very well in the picture with the clinical manifestation of the two diseases. The other thing is that we should look for autoimmunity in autosomal dominant hyper IgE. We know of some patients that manifest with lupus-like phenotype. This is not the case, but we should look for autoimmunity in autosomal dominant hyper IgE. At the same time, we should look for hyper IgE signs in STAT3 gain of function disease. Also, when we found unexpected value of the helper 17 or IgE values that are unexpected for the mutation that we are looking into, we should think of this hybrid mutation. And the other very important, I think, educational message that comes out from this case is that we should reconsider literature data on specific mutation. The mutation that we had found and where we could have stopped has been described as an as responsible of autosomal dominant hyper IgE, but this happened in 2008. When it was probably sufficient, where first of all a gain of function disease has not been described yet, and it was sufficient to describe the phenotype to see that those patients didn't have T helper 17, And that was enough to say this mutation is responsible of autosomal dominant hyper IgE. But years later, we should reconsider and we should perform the functional tests. Also, the other important thing that I think goes beyond STAT3 is that when we have multifunctional protein with pleiotropic function like STAT3 and that are extremely that are regulated in an extremely complex way, mutation may cause loss of some function and gain of other function. Also because, as everybody knows, STAT3 does not work alone. It is very complexly regulated, but also works in dimers. And this can be homodimers of STAT3, of a STAT3 mutated, and of another allele that is wild type. But also it works in heterodimers that are STAT3 mutated or not, with STAT5 or STAT1. And this makes things extremely complicated to be interrogated with simple tests. So this is what we have had in mind up to now, that there is a loss of function and a gain of function of STAT3, but actually STAT3 functioning is a matter of balance, and hypo and hyperfunctioning can cause disease, but not in a strictly dualistic way. I sort of imagine STAT3 in a line of balance, and this is the wild type. When we go out of this line of balance, STAT3 may lose some function, may gain other function, but it can also has an hybrid phenotype. The thing is that the disease is outside the line of balance. And so with this, I think it's necessary to start moving forward this dualistic scheme that is very didactic, loss of function and the gain of function. But I think that this confusing phenotype that our patient had should push us forward beyond the loss and gain dualism. And with this, I thank you for the attention. I thank all the colleagues of the rheumatology unit of Meyer Children's Hospital that referred us the patient and with which we collaborate every day. All the clinicians that works that are my colleagues and works in the immunology unit, and there was not enough space for them here, but all the people of the laboratory of immunology of Professor Azzari we work with every day. They are our colleagues too. And all the group of Freiburg, especially Laura Eva Faletti and Maria Elena Maccari of the group of Professor Stefanel that help us to discover a little bit more about this case. Thank you.